There are just a few more people joining us, so I'll just wait a minute for more people to come online.
Thanks, Cara.
Okay, so welcome everyone to this webinar. Thank you for joining us today. I'd like to start this webinar with an acknowledgement of country. So I acknowledge the traditional owners, the Turrbal and Shargra people, and their custodian of the lands on which we meet today. On behalf of the Tobacco Endgame Centre of Research Excellence, I pay our respects to their ancestors and their descendants who continue cultural and spiritual connections to country. We recognise their valuable contributions to Australian and global society. Today we have a presentation from one of our CRE Associate Investigators, Dr. Gary Chen. Gary is an NHMRC Emerging Leadership Fellow at the National Centre for Youth Substance Use Research. His principal research interest lies in the field of substance misuse prevention and the application of cutting-edge statistical methods for longitudinal analysis and causal inference. His recent publications have been focused on polysubstance use, including tobacco and cannabis, and the profiles in adolescent populations. He's also looked at examining the urban and rural differences in substance use and the epidemiology of alcohol, tobacco and cannabis use. Gary has also served as a consultant at the United Nations Office of Drugs and Crime to improve existing methods for monitoring global trends of illicit substance production, trafficking and use. And he's a Deputy Statistical and Methodology Editor for the journal Addiction. So Gary will be presenting findings today from his research on the impact of tobacco control policies on adolescent vaping. So just some housekeeping. Could I ask that everyone please keep your microphones on mute for the duration of the webinar? And if you have questions, please put them in the chat window. And at the end, hopefully we'll have time to go through as many of these questions as possible. So I'll put them to Gary, so just type your questions into the chat and then we'll get to them at the end. So now I'll hand over to Gary for what I am sure is going to be a very interesting presentation. Thank you, Gary.
Thanks, Cara. Let me share my screen first. Okay. All right, so can everyone see my screen?
Yes, it's good, Gary.
Yeah, thanks. All right. So as Cara just mentioned, I'm a statistician and epidemiologist, and my recent research interest is on tobacco epidemics and also adolescent vaping. So just to give a bit of background of the tobacco epidemics, combustible tobacco kills 7 million people directly every year and 1.2 million through secondhand smoke. Therefore, ending the tobacco epidemics is a global health priority. The main public health approach to end this epidemic is through demand reduction strategy. This strategy usually aims at discouraging uptake and also encouraging quitting among smokers. A lot of smoking cessation interventions are also provided to smokers. There's a few different types of interventions. For example, behavioral interventions, including cognitive behavioral therapy, CBT, pharmacological interventions using variant nicotine replacement therapies using nicotine patches, nicotine gum. These interventions are very effective. However, the effect size is, I would say, small to moderate. Recent trial shows that only around 10% of smokers who use NRT stop smoking after 1 year, which means that the failing rate is nearly 90%. Keep in mind that this is already much higher than unassisted quitting attempt. And also, the relapse rate is very high. It can be over 50%. So like some smokers might be able to attain abstinence at some point, but the long-term abstinence rate is still quite high because many of them relapse. So it is where e-cigarette come into place and come into the debate. E-cigarette is a battery operated device that heat up and vaporizes solutions that may or may not contain nicotine. Most of the harms from combustible cigarettes are from the burning process. Nicotine is highly addictive, but much less harmful than other harmful chemicals released during the burning process. Michael Russell, a pioneer in tobacco harm reductions, once said that people smoke for nicotine, but they die from the tar. So, e-cigarette might be able to use as a cessation aid. Many smokers claim that e-cigarette help them quit smoking. And many prefer e-cigarettes as a cessation aid compared to traditional nicotine replacement therapy, such as gum and patches. There's a few reasons for that. One is could be similar hand-to-mouth actions that smokers used to, the sensations of inhaling some vapor, and there could be less or similar side effect compared to NRT. And recent generation of electronic cigarettes are relatively effective in delivering nicotine to address withdrawal. All right, so it sounds pretty good, but does it really work? Myself and my team and Coral have conducted a systematic review and network meta-analysis to answer these questions. We identified 7 electronic cigarette trials and 9 nicotine replacement therapy trials with a combined sample size over 10,000 smokers. Then we conducted a network meta-analysis to compare the effectiveness in helping smokers to quit between nicotine-containing e-cigarette versus NRT, and also nicotine-containing e-cigarette versus nicotine-free control conditions, such as counseling or nicotine-free e-cigarette. So the figure here summarizes the key result. And participants receiving nicotine-containing e-cigarette were 49% more likely to remain abstinent than those who receive NRT. We have the combined estimate here. The relative risk is 1. The risk ratios or the chance of quitting that is 49% higher. Participants receiving nicotine-containing e-cigarette were 109% more likely to remain abstinent than those in nicotine-free conditions. This is this estimate. The risk ratio is 2.09. We do also have an estimate comparing nicotine replacement therapy and control conditions, and the estimate is around 1.40, which means that nicotine replacement therapy is of course like 40 effective, and it is 40% more effective than unassisted quit attempt or nicotine-free quit attempt. So these evidence suggests that nicotine-containing e-cigarette is one of the most effective smoking cessation aids. Therefore, there will be huge health gain if smokers switch to e-cigarette completely. However, e-cigarette is highly controversial. Why is that? Because of the rapid uptake among young people. Many worry that it might create new generations who are addicted to nicotine. Many also worry the gateway effect. What is a gateway effect? People worry that young people who started vaping may transition into tobacco smoking. This is what we don't want, because tobacco smoking is very, very harmful and it kills a lot of people. Longitudinal studies have consistently demonstrated that non-smoking teens who vape were subsequently more likely to smoke cigarettes. So many of the cohort studies have established a temporal relationship between vaping and subsequent smoking. But the question is how strong these evidence are for a causal interpretation that vaping causes smoking. To answer these questions, my team conduct another systematic review and meta-analysis. And we find 11 longitudinal studies of young people who were non-smokers at baseline. These studies have a combined samples of 50,000. And this is the result of forest plot summarizing the effect from the 11 studies. We find that there is a very consistent association between baseline vaping and subsequent smoking. The risk ratios are all over, the adjusted odds ratios are all over 1. However, we did find that there could be a strong publication bias because that we find that study with a smaller sample size generally reported a much higher odds ratios, much larger effect size than study with a much bigger samples. And could we have a causal interpretations of these evidence? To evaluate the evidence for causal interpretations, it is important that we identify key confounding variables based on well-established psychosocial theories from developmental psychology. For example, in this study, I use the social development models and social ecology models from developmental psychology to identify key confounding variables. And I count how many of these studies have adjusted for these key confounding variables. Key potential confounders could be parental smoking and peer smoking. We know that for young children, parents is always a role model. When they grow up and enter at the adolescent phase, we know that peer also serve as a model of what behavior is acceptable and what is not. So parent smoking and peer smoking could be a key confounding variable. School performance, school commitment, and school connectedness could be another important confounding variables because we know that young people who are disengaged from school, disconnected from school, or those who are and those who have very poor school performance are more likely to use electronic cigarettes and also smoking. Susceptibility to future smoking, alcohol and other drug use at baseline, and other deviance behavior at baseline. All these are key important confounding variables that could link to vaping and smoking. So it is essential to adjust for these key confounding variables. And it should be noted that the list I have here is not exhaustive. For example, I haven't looked at other mechanisms such as biological mechanisms, including genetic risk. So this is a table summarizing the number of confounding variables that is adjusted for in all these 11 studies. What we find is that the majority of these studies only adjusted for one of the variables. For example, in Wales, 2017, this study only adjusts for deviance behavior, but haven't really adjusted for all the other key important key confounding variables, such as parental smoking, peer smoking, school commitment, susceptibility to future smoking, and other alcohol and other drug use. Only two of the 11 studies have a reasonable amount of level of adjustment for confounding. Previous review and meta-analysis argue that overall there's good adjustment for confoundings because many confounders are adjusted for in various studies. However, this is an invalid and wrong argument because confounders needs to be adjusted for in each of these studies. Insufficient adjustment in individual studies resulted in bias estimate. So in a meta-analysis, if we pull all these bias estimates, we only end up having a bias estimate at the end. Even overall, many confounders were adjusted for in different studies. So what we find is that only a small number of studies adjusted for a good number of key confounders. And we need to bear in mind that our list of key confounders are not exhaustive. Like what I mentioned before, I haven't looked at genetic risk because none of these studies have looked at that. Many of these studies are also sensitive to confoundings in a way that a variable with moderate confounding effect can completely negate the result of the majority of these longitudinal study, which means that it would bring the effect size they find down to zero. The approach I use is called evaluate approach. It is a rather technical approach. For those who are interested in that, they can look at the paper here, this paper. And even though there is a causal effect, it is likely to be small. Why is that? Professor Wing Hong and myself published a commentary this year, and we look at genetic study, and this study demonstrated that a substantial proportion of the vaping and smoking associations can be explained by common liability. That is a underlying causal factor that causes both vaping and smoking. One key example of common liability is genetic propensity of smoking. And another type of common liability could be personality traits such as impulsivity and sensation seeking. And also, if we look at a time series type of analysis, and we look at data from the United States, what we find is that smoking rate continue to decrease or even accelerate when vaping increases. At population level, vaping may have actually displaced smoking instead of causing young people to smoke. This is another study that my students and my team published. And this is a figure of the trend of regular e-cigarette use and regular cigarette smoking from two largest nationally representative survey in the United States with a combined sample size of over 200,000. The yellow line are the trend line for smoking, cigarette smoking. And the blue line represent the prevalence of e-cigarette use, regular e-cigarette use. And we can see a very strong decreasing trend of cigarette smoking, while there's a very strong increasing trend of electronic cigarette use. However, we need to bear in mind that electronic cigarette is not harmless. Regardless of whether vaping causes smoking, youth vaping could be a public health concern because vapor from e-cigarettes still contain a cocktail of harmful chemicals. Nicotine is highly addictive, although its harm is much less than other chemicals released from the burning process from combustible cigarette. Therefore, youth vaping should be discouraged. Currently, global tobacco control policies are guided by the World Health Organization's Framework Conventions on Tobacco Control, WHO FCTC. This is the first WHO treaty that is legally binding in 181 ratifying countries. And it came into force in 2005. The WHO later also provided the MPOWER policy package to assist in the country-level implementations of effective interventions to reduce demand of tobacco products. So what is MPOWER? The M of MPOWER stands for monitoring tobacco use and prevention policies. P, protect people from tobacco smoke. O, offer help to quit smoking. W, warn about the dangers of tobacco. E, enforce bans on tobacco advertising, promotion, and sponsorship. R, raise tax on tobacco. So these are pretty vague. So what a more solid examples could be for monitoring for M. We WHO require reason, representative, and periodic data for both adults and youth. For P, it requires legislations on smoke-free environment. For O, it requires cessation programs such as National Quit Line, and that both NRT and some form of smoking cessation service are paid for. For W, it requires large warning labels with all appropriate characteristics. For E, it requires national anti-tobacco campaign and advertising ban. Lastly, for R, a high level of implementations means that at least 75% of the retail price of the tobacco product is taxed. There is very strong evidence that the implementations of MPOWER policy package can reduce tobacco use. But what are the impacts of MPOWER and e-cigarettes among young people? Does it work? So to answer these questions, I use data from the Global Youth Tobacco Survey. This is a WHO initiative that uses standardized methodology to collect data on youth tobacco use from school students, typically aged 13 to 15 years old. And in this study, I used data from 44 countries to test the association between implementations of MPOWER policies and youth vaping. The combined sample size is over 140,000. Two of the key measures, of course, are vaping. It was measured in using a single items during the past 30 days on how many days did you use electronic cigarettes. For past 30 days vaping, I call that as yes and no based on the response to these questions. And also I have another variable, past 30 days frequent vaping. It is defined using a cutoff of 10 or more days. Less than 10 days, no, and 10 or more days, yes. So the key predictors would be MPOWER implementation. The WHO evaluated the implementations of monitoring policies and rated it from 2, that is no known data or no recent data, on data that are not both recent and representative, to 5, recent, representative, periodic data available for both adults and youth. The other 5 policies were rated from 2 to 5, with 1 indicating no available data for assessment. Then I conduct a very standard procedure using mixed effects logistic regressions. Past 30 days vaping and past 30 days frequent vaping were regressed on implementations of the 6 MPOWER policy. Vaping was measured at individual level and implementations of MPOWER policy were measured at country level. And in this analysis, I adjust for sex, age, which are individual level variables, and country income level, which is which is of course a country level variable. I also adjust for multiple testing because I'm testing 6 associations in 2 different models. The level of statistical significance was limited to 0.004. This is part of the result, and these are the prevalence from a couple of countries in the Americas. There's quite large variations in prevalence estimate. And also we find that frequent vaping is relatively rare compared to just like past-month vaping. And there's a reasonably good coverage of countries from different level of development, like some from high income countries, some from low middle income, and some from upper middle income. The response rate is generally quite high. And this is the level of implementations of the 6th policy in 44 countries. We can see that in only a small number of countries have attained the highest level of implementations of all these 6 policies. So many of these countries have some level of implementations, but it hasn't achieved the highest level yet. And this is the result from the logistic regressions. It is a very busy table. What I want to draw you is, I want to draw your attentions to the result at the bottom, which is showing the association between taxation and vaping. For all the other 5 policies, the association is largely non-statistical significance, and the effect size is very small. For taxation, what we find is that higher tax is associated with higher level of vaping. The story is the same for past 30 days frequent smoking. Past 30 days frequent vaping. The direction of association is exactly the same. Higher level, higher tax on tobacco product is associated with higher level of past 30 days frequent vaping. So what are the interpretations of these results? First of all, there's large variations in youth vaping. Past month vaping ranged from 2.4% in Cambodia to 33.6% in Guam. Guam is a small island in the Pacific Oceans, and it is a jurisdiction of the United States. It is included here because there's a separate survey on this region. Most adolescents report vaping, only vape very infrequently. There could be a few possible explanations for that. The first one is e-cigarette is relatively new. There might not be a lot of established vapor. And these products are often sold in very colorful packages with highly palatable flavors, like as you can see from the right-hand side, very colorful packaging. These are the e-liquid, and it can be used in electronic cigarette. And these type of products may lead to more experimentations, but not continual use. The last explanations could be that adolescents may also vape non-nicotine or low nicotine concentration e-liquid. Therefore, they are less likely to be addicted to nicotine. Globally, overall, there's no consistent approach to regulating e-cigarettes. Some countries treated it as a consumer product, some treated it as a medicinal product, some as tobacco product. Many simply don't have any regulations. What we find is that 5 of the MPOWER measures do not have any impact on youth vaping. The only one that is associated with vaping is taxation. However, higher tobacco tax is associated with higher level of vaping. This could indicate that there is possible substitution effect. Adolescents in countries with high tobacco tax may be substituting combustible cigarettes with e-cigarettes. This could be beneficial to public health if these are the adolescents who would smoke without e-cigarette availability. For example, adolescents at high risk of smoking, those living with smoking parents are usually at a much higher risk of smoking. And if these adolescents now vape instead of smoke, that could be beneficial to public health. This interpretation is also consistent with time series studies from the United States and United Kingdom, suggesting that e-cigarette may be accelerating the decline of youth smoking. However, rapid uptake among young people is concerning because e-cigarette is not completely harmless. it is very likely that some low-risk young people might not have used e-cigarette if it were not available. Therefore, we would still need strong regulations to protect young people from vaping. Existing MPOWER measures are effective against tobacco smoking. We could specifically include these e-cigarettes into these policy measures. For example, in many of these countries, we would need to ban advertising and promotion. We would need to implement age restrictions. We can also potentially use a differential tax rate to maintain a price difference between e-cigarette product and smoking product. Young people are price sensitive. We can maintain a high tax rate for combustible cigarettes, a lower one on e-cigarette. In this way, we could encourage smokers to switch because there's still some financial incentive, but we can discourage young youth uptake. So what are the implications to Australia? In our country, we have one of the strictest policies on e-cigarette among high-income countries. This policy may have reduced youth vaping at the expenses of smokers. Nicotine vaping products require prescriptions you cannot easily buy. And this could create barriers for smokers. And it also increased the cost for vaping. We need to bear in mind that the most deadly form of nicotine, combustible cigarette, is still widely available. You can easily buy cigarette from shopping center, from supermarket, petrol stations, and news agency. And during the Brisbane lockdown, I do notice that Signal, one of the tobacconists, is still opening, and apparently it was treated as an essential service. What we can do to encourage smokers to quit could be to make e-cigarette more accessible, but combustible cigarette less accessible. For example, we can allow e-cigarette and combustible cigarettes to be sold only in licensed premises. And we definitely need to restrict licensing. And other options could be we can provide e-cigarette as a free cessation age for a certain period of time for smokers. My team is now currently conducting a cost-benefit analysis of this type of interventions, giving e-cigarette for free to smokers with prescriptions in Australia. Substituting combustible cigarette with e-cigarette can result in huge public health gain. The cost of providing e-cigarette for free to smokers is much lower than the medical cost for treating diseases resulted from combustible cigarette smoking. Other things that we need to consider could be specific regulations for social media. This is a new study from my student. She looked at Tanti's son and my team. She looked at vaping on TikTok. And these videos are very, very popular on TikTok. And TikTok is a very popular social media platform for young people. And many of these videos portray vaping very positively, glamorizing vaping. And we do need to have a very strong regulations on social media to prevent young people from watching these videos. Lastly, I would like to acknowledge my collaborators and co-author of this study and NHMRC Investee Grant. If you are interested in this area of research, you can follow me on Twitter or send me an email. Thank you very much, everyone.
Okay, thanks so much, Gary. That was really interesting and a great overview of quite a few studies that you've conducted over the last couple of years. So that's great bringing it all together. We don't seem to have, oh, hang on, here we go. We do have some questions in the chat. So I'm just going to start going through some questions now. So I've got a question from Ron Borland. Has anyone looked at the effects of the set of measures used on any on regular smoking? So regular youth uptake and regular smoking.
Yes, we have quite strong evidence that the MPOWER measures is effective. Like particularly the taxation is one of the strongest policy to deter smoking in general.
Okay. So Ron, did you have a follow-up question on that? I see your hands up.
Not so much on that, but on the earlier stuff, on the demonstration of the meta-analysis of the study showing the strong association between any vaping and subsequent smoking. You talked about the potential confounds. Have you done an analysis looking at how much each confound, sort of done numerically, reduces the magnitude of the effect, and whether it's plausible that if you controlled for all of them and confounds that are missing or only partly controlled for, that the effect would completely disappear or even reverse?
We haven't specifically looked at the confounding effect, like how of individual confounding variables, but we do use an approach called the evaluate approach to evaluate if there's a confounding variable, how large the effect it needs to be to negate the conclusions. And what we find in our paper is that we don't need a very strong confounding variable to negate half of the study to be completely zero, the effect of half of the study to be completely zero, which means that it's very plausible that many of the reported associations could be negated if there's sufficient adjustment for confounding.
I think that's a really important conclusion, Gary, because the other population-based stuff that you talked about is showing that the two are going in opposite directions. If vaping was actually leading to more smoking, it would be a force for increasing the smoking rate in the context of vaping, increasing at a population level. That it's going in an opposite direction would suggest that that there would need to be, that there are some very strong forces at work, much stronger forces at work pushing smoking down, and that if vaping is having any effect, it's more likely to be supporting the reduction in smoking, or that its effects are so small that they're hardly worth worrying about.
Yes, that's correct. Yeah, it's what from the population data from the United States, what we find is that there's nearly no population level effect of vaping on smoking. However, having said that, like vaping could still be a concern for young people because like vaping itself is not completely harmless. So therefore, we will need policy to discourage vaping, but also have policy to encourage smokers to quit potentially using vaping product.
Okay, I have another question now from Natalie Walker. Natalie, did you want to unmute and ask your question?
Thank you. Gary, could you go back to your 2 slides that had the taxation and you had it highlighted in red?
Yep. So this one?
Yeah, I think the next one as well. Maybe the next one might be a better example.
Okay, just give me a second. Yep.
This one. I just wanted to ask you a question about the effect sizes that you've got here. So you've got quite large point estimates, and you've got very wide confidence intervals.
Mm-hmm. Yep.
So how much do you feel that these results are potentially spurious because you've run into a sparse data issue, or how much do you think that it's an actual result? So the wide confidence intervals indicate that you've probably got very little data in there. And so yes. I'm just wondering whether these results should be interpreted with a little bit more caution.
So what these results, these are the frequent vaping. And if we look at past 30 days vaping, the effect size, the confidence intervals is a lot narrower. The reason for that, for the wide confidence intervals, I believe, is that past 30-day frequent vaping. It's very, very rare in many of the country. If we look at this, the prevalence of frequent vaping is very, very low in many countries, even in countries with a generally higher level of past-month vaping. The frequent vaping is quite low. So therefore, it resulted in a very wide confidence intervals. But having said that, the lower bound of the confidence intervals is still showing a reasonably strong effect. Which means that, I believe that it's a genuine effect.
I agree, but I was just wondering that maybe we can't put so much weight onto it as much as you would want to, given that broad degree of error there. But I just wanted to just ask your advice on that. So thank you.
Yeah, of course. Yeah, like as you said, like this study, we only have data from 44 countries. It could still be spurious, but but if we look at the lower bound of the confidence intervals, and especially I have fully adjusted for the confidence intervals in a way that in traditional study we use 95% confidence intervals, but because of multiple testing here, the confidence intervals is 99.58%, which is a very conservative estimate. And under this estimate, we have the lower bound of that still showing an effect size. So I believe that the effect is still there.
Can I ask one more question?
Sure.
Is that okay, Carol? To go back to that slide where you showed the trend for smoking against, it was a line graph showing the smoking against the vaping.
Yeah. This one?
Yes. So, so at each of these cross-sectional surveys, it's a different population of students. So I wondered if the data, I'm just seeing what age were these children? That was everyone lumped together. I was just thinking if you looked at the different age groups in each cross-sectional, so in 2014, the 14-year-olds, and then in 2015, you look at the 15-year-olds, because that cohort of 14 that a year later are now 15. So that's where you would, so I just wondered, has anyone looked at the data that way? I know it's not perfect, it's not a longitudinal study, but it's showing maybe that progression of that same cohort.
Yeah, that's a very good suggestion. I'm not aware of any study have look at that way. Yeah, potentially. Yeah, I believe that we can look into that. We should have enough sample size to look into that. That's a very good suggestion, and we can look into that.
Yeah, just wondered. Yeah. Okay, thank you.
Thanks, Natalie.
Do we have any other questions for Gary?
I've got another one, Coral, if it's...
Go ahead,
Gary, can you go back to the slide on the 30-day vaping one? Having it up for a bit longer led me to look at it, and the cessation programs. There seems to be a strong negative association between the prevalence of cessation programs and 30-day vaping. I'm not sure what the effect is for the more frequent vaping, but that's something you really didn't mention in the talk, and the effect seems to be of a similar magnitude, perhaps even slightly stronger than the effect you've got for taxation. So could you comment on that?
Yes, that's one thing that I am inclined not to overinterpret that result. The reason for that is we know that all these let me sorry, okay. So what I would like to draw you is that these 6 MPOWER measures are highly correlated, and that in the unadjusted models it doesn't show any effect, but in the partial adjusted model it also doesn't show any effect, and it only shows an effect in the fully adjusted model. And this could, so my interpretation of this is that it could be because due to dependency in these variables that cause that problem. And the same as the other variable that I have here is, it looks like that advertising ban seems to be having an effect in the fully adjusted model, but it doesn't have any effect in the other model, in the unadjusted and partially adjusted model. So I would call that the effect is not consistent. And it could, again, due to the correlations between the variables instead of a genuine effect. So I would not overinterpret that result. And similarly for cessation program here, we have a strong effect only in fully adjusted model, but not the other model. So it could be due to correlations and dependency between the variables.
If the effects get stronger, I mean, the advertising one, you've got the stronger effect in fact becomes a lot less. Yes, there's not any sense of linearity there. And if you looked at your consistent one, there was a trend in the opposite direction. So I think the advertising one is more likely to be a spurious effect. But the cessation one seems to be pretty consistent. If there's anything there, the rates of vaping tend to be considerably lower. So I think it's at least worth thinking about, because in the fully adjusted model, you are controlling out for the effects of all these other things, hopefully. Although statisticians like to let people assume that you've controlled them all out when you put them in there, but of course we know that you don't. But I think it is worth thinking about as to what the possible implications might be and whether it's worth following up in a more systematic way.
Yeah, that's a very good suggestion. Yeah, it's definitely worth following it up. Just like because of this study, we for some of the dependency we in between the variable, we were not able to fully adjust it for. So I'll incline that to be a more open question. But for taxations, because the effects very consistent across all the models, and I'm more confident to interpret that as a genuine effect.
But if you're taking if a substitution model is plausible, then you may expect less substitution in places where there were smoking cessation programs available. Admittedly, they're not used at all by kids, so this is a somewhat tenuous argument. But the focus there is on encouraging complete cessation with supports around for adults, so the kids see that as more of a goal, whereas in places where there aren't cessation programs, it may be more likely to be used as a substitute by the kids.
Yeah.
Now, I've got a question from Michael Farrell. So do you, Michael, if you would like to ask a question.
Yeah, Gary, thanks very much for that very interesting presentation. You mentioned TikTok and social media. I wondered if you've got any data on the impact of social media, whereas my impression would be that there's not much data around on it.
Yes, you're correct. Yeah, there's not much data. And I did have two PhD students looking into that and designing some experimental study and also collecting some survey data to look at how exposure to social media would impact on young people's preference of e-cigarette use and also other substance use. And so you can watch the space. There could be some publications from my team next year.
Okay, thanks.
Do we have any other final questions for Gary? No? Okay, so I'd like to thank you all for joining us, and I hope that you found this interesting talk to start thinking about the relationship between tobacco control and e-cigarette policies. Okay, so thanks again, and we hope to see you again next time. Okay.
Thank you very much, everyone. Thanks, Coral. Bye.